I mean, they're walking all the way up these steps or going through the elevator. They got to find their way to the back of this building now. And now you want them to walk down the hallway to register? Now, I don't know how I'm going to win that battle because I'm a very small pod, pea in the pod, and there's a lot more people that are more important than I am. But, we're all feeling very strongly about that. Why should our patients suffer more so than they already are when they're coming in because you don't want to have somebody sitting maybe in a nurse's station somewhere? So we'll see how that goes. The little bulldog in me has been fighting for that for a couple weeks now.
Sure.
Yes.
Am I not getting something? What's the significance of the bird in the equity?
That's the Robert Wood Johnson logo.
Oh, that's a little
I
bit.
know, there's some significance that I'm totally missing.
Yeah, we're chasing the bird. So let's talk about how can our minds impact our care with our patients. So we really have to make sure that what we are doing, our unconscious stereotypes and prejudices don't come out in our day-to-day jobs. And we need to make sure our attitudes and beliefs, if they are not something that is empathetic to people that you're working with, that you try to convert yourself to making yourself understand the empathy of individuals you're working with. And that's in any place. But I really want to always feel like I can't sit and say to you, I know what it's like to be African American. This is why I don't like to give this talk. That's what I said earlier, right? I don't know what it's like to be African American. I don't know what it's like to have sickle cell disease. I don't suffer from a chronic illness. I truly can't relate to you. But what I believe that I've done over the last 15 years is demonstrate to the patients that I work with that I'm here to listen to you and I'm here to help you. And I think it doesn't matter what we look like in order to be able to do that. I think there has to be that sincerity that you are doing all you can, that you are understanding that even if I'm learning at an early age, maybe I think I did. I think I was taught a little bit differently. My father was a good man, but I think sometimes I think back some of the things that he said, I'm like, ooh, maybe, Archie Bunker time, I don't think there was a lot of things that I would believe, that maybe right now would be true. But I always wanted to feel like when I was working with our patients that they at least understood that I was there for them. And so I think these are some things that when we're really doing our day-to-day work that we need to keep kind of in context. And sometimes you check those feelings at the door. We had a wonderful nurse practitioner back in the day. White lady, long gray hair. Those of you who've been here for a while, Virginia Smith, Walter's laughing, that's exactly what we're talking about. That woman worked tirelessly, and I mean tirelessly, 24/7, 365 days a year, had patients over for tea, crumpets, they did all kinds of stuff. She was at the hospital at 3 a.m. if somebody was admitted. But I gotta tell you, don't ever talk politics with her, because her version of life was completely different than most of the patients she was working with. But they loved her, and they knew that she was there for them. So it was okay that she was different, because she was able to kind of conform and let them understand that she was there for them. And I mean, sure Walter can say when he comes up here what his thoughts were about that.
Yeah.
So I think I talked enough. I'm just going to go through a couple of these slides because I really want to make sure we have time for Dr. Lawrence, because I think what she has to say is extremely significant. But I wanted to make sure we also talked a little bit about the disparities that we're seeing in our sickle cell disease patients, and understanding sometimes how rude and disrespectful staff are to our patients. I would think that after all this time, I would not hear these same comments being made, but God, it's true, it hasn't changed. And I think a lot of times it just depends on where you're at. In our institution, and you're going to hear from a wonderful emergency room doctor here later today, he became part of one of our champions, and he's worked really hard to change the identity of patients with sickle cell disease coming into our emergency room. And I think that, we almost have to say it's like a step-by-step process. If you could find that champion somewhere, and again, he's Caucasian, obviously doesn't have sickle cell, but very compassionate individual working and listening. And the first time we met with him, I remember Dr. Smith and I going into this emergency room meeting because we were just got our medical home, and we're like, we're going to just let them tell us what they need, and blah, 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 and blah, blah, blah. And he's like, you tell us what you need. We don't know what you need. You tell us how to take care of these patients. And we were like, oh, okay. And that's what we've been doing for the last 6 years. So that is also why our patients don't want to go to the emergency room, right? Sometimes it costs them their life because they don't want to go to the emergency room. During COVID, it was never more apparent to us that the fear mongering to go to the emergency was greater. And so we actually took time, I think we were about 6 weeks into the pandemic then, and we called every one of our patients. All of our staff took turns, we called people, we screened them for depression. I think back now, we should have maybe re-screened them in 3 to 6 months because we didn't know the pandemic was going to go on as long as it did. But we wanted to make sure that they were okay because they didn't want to go to the emergency room. Not only were they afraid from their past experiences, but they sure as heck did not want to get COVID and die while they were there. But we all knew at that time how serious the situation was. And we also want to make sure we're documenting the problems that our patients are having. I feel like we've had a significant decline in patient relations since our medical home has come into fruition 6 years ago. I give applauding hands out to the people in the back of the room over there on the left-hand side who are members of our team because I think they work really hard to take care of the issues with the patients either at the time or in some other capacity before it gets to somebody calling patient relations. But if they want to call patient relations, here's the number. And I just recently had a conversation with someone on my team, and they're like, well, sometimes I'm not sure patient relations is really like dealing with maybe some of the small things anymore, or maybe they're not being heard, or they hear the same things over. And I said, give them my number. They can call me. So I think we just have to be aware of that. So, we have 3 types of cultures. We have the patient's culture. We have to take into consideration their feelings and how they're, what's impacting them. We have the physician's culture. I think you heard yesterday how much time is spent on sickle cell disease in medical school. Maybe a page, maybe a half hour. And then we have society's culture, which we all know right now is really dark and bleak. So you try to put those 3 things together, so how do you make things better for our patients? Well, we want to make sure when we're looking at our patients that we see that they also see things probably in different ways during different times. The private phase is where they feel really helpless. No one's listening to me. And sometimes it really doesn't matter how great your program is. Sometimes a patient is still not going to think you're listening to them. And we're going to get into that discussion here in a minute. Then you have the clinical phase. Oh my gosh, when I go to the emergency room, I don't care how sick I am, I gotta put on that makeup, my best clothes, I gotta go in there looking fancy. Otherwise, someone's gonna think I'm a drug seeker, they're not gonna want to take care of me, especially if it's a hospital that doesn't know you. So I hope at VCU our patients don't feel they need to do that. I'm hoping, I've not really heard that they had to, but I know many talks that I've been to and many patients that I've talked to when they go to the surrounding hospitals, they do exactly that. And I'm talking about even I can specifically think of one of my colleagues. She's a parent of a patient with sickle cell trait. She has a PhD, and she dresses up to take her child to the emergency room so someone does not think that about her child. Isn't that sad? I think that's really sad. And then, of course, we have the society phase. What do we say as a patient, maybe when you're out in society? Oh, those people at VCU, they really don't care about me. I go in there, they don't take care of me, that doctor doesn't listen to me. Oh, when I go to VCU, I have the best care. My doctors really listen to me. I'm really happy with how they're treating me. I got this patient navigator, I can call her. I'm hoping that's a conversation. But I don't know, right? We don't know. Because we all wear different faces at different times, depending on what we're doing. So this is just a really busy diagram, but it talks a lot about the different treatments versus self-management of care for patients. And so how things are from a psychosocial perspective, how men and women are different. It's kind of busy, but I did just want to put it up there. This is a slide Dr. Smith has used many times. I liked it enough that I thought at least you should see it. And now we're going to talk about stigma. So, we all know sickle cell patients have had lifelong barriers to accessing good care and treatment. Even today, Even with the American Society of Hematology investing in the last 5 years to train multiple centers across the country, there is still access to good care for sickle cell disease. Many patients who live out in rural areas, they don't have the ability to get in, they're 2 hours away. So they suffer needlessly at home. Or they suffer, period, because they don't even have a doctor that they can go to. I don't think we have that problem here in Virginia, but I know we have that problem everywhere else. They don't trust us. And until you learn how to build relationships, and Haley Hartsock is going to talk about relationship buildings a lot on the 4th day, which I think is really, oh, there goes the screen again, which is really important. I think we just need to make sure that we have our patients try to gain our trust. That is one of the most important things that you can do with anybody. If you don't trust somebody, you're not going to tell them the things that are important. You're going to tell them what they want to hear, or you're going to do what you think they want you to do. Patients do sabotage their own care. We all know that, right? We have morning huddles every morning. It's been going on for the last 4 years since the pandemic, and we keep doing it. And sometimes we are just as frustrated as probably a patient is. Because we know that we need to give them these tools. I'm going to use mental health as a great example. You know, many patients, many people in general are afraid of the term, you know, I'm depressed, I have mental health problems, I need to see a therapist, whatever that situation might be. But many times now, we realize the trauma that has gone on with sickle cell patients, the medical people can treat the medical part without a problem. It's the psychosocial and mental health pieces that we really feel that those patients need to have. Well, we go in, we might do an assessment on them, and I'm not going to steal Haley's show because she has a great presentation tomorrow. But it's like they don't want any help. What do? There's a great video she's going to show you. Black people don't go to therapy. I was watching Good Morning America about 4 weeks ago, and I meant to pull this verbiage for them, and I forgot. And there was 3 athletes who were African American, and they were talking about their own significant mental health problems and how embarrassed they were to ask for help. Until one of them had a sibling who committed suicide. How another one really literally could not get out of bed the next day. And they finally went and got some help. And they're like, and now it's our mission to try to get people in the Black community to go and get mental health care. You're burnt out. Now, it's not just having to take care of a patient with sickle cell disease, but like I remember taking care of my mother when she got older. It's hard to be a caregiver. Most of the time, if you're a caregiver of one, and you're tired. You're trying to maybe balance work, you might have other children, you might have a marriage that's going down the tubes, whatever the circumstances are. It is hard to be a caregiver. And there's so little resources out there, period, probably unless you have cancer, that are going to really help you. Or unless you're really, really poor and you happen to get off that wait list for a waiver that someone's going to give you. We all know what the wait list looks like. There's no end in sight for most people to get off a wait list. And social workers in particularly struggle with this, and I'm a social worker by training, suffer from this repeatedly. We bang our heads against the wall. I've had conversations with members of my team that are like, I just am tired of not being able to solve a problem. And it's a hard thing. Some of us do okay with that, and some of us struggle with that. And I always say, if you got that one success, hold it and carry it with you. Honestly, if you get a great text message from a patient and they tell you how amazing you are, I'm like, frame that, put it on your wall, write it on your mirror. And it's not because people don't appreciate you, but many times they don't say things, and you just need that one thing to maybe keep you going for the next 6 months to a year. Seriously. Do we all feel that in this room sometimes? So, again, I'm taking up more time here. So I just want to go briefly through this because I do want Dr. Lawrence to come up. There are 4 domains of stigma. We want to focus on these, and these slides are available for you. Current literature reveals that sickle cell disease stigma has detrimental consequences. We're all well aware of that. Future research does need to impact the health-related stigma on self-management of stigma. And I do believe that we have more grants now. Dr. Lawrence might be able to nod her head yes or no if I'm right. But I do think we have more opportunities through research to really go out there and try to tackle this problem.
No, a lot of y'all
Even
play
though
the
we do
victim.
have the fake DEI offices out there, I do feel that some of them really are trying to make a difference. And I will tell you that I had, for the first time, met our DEI officer, and she's phenomenal. So we are now going to start partnering together to see what we can do to help continue to
Telling
improve
y'all,
our
I'm not here to be
relationship
like,
with the community for our sickle cell
and
patients.
I know that.
So,
Take it how you
again,
want.
stigma versus bias. I don't want to go over all this again. I think, we've kind of heard enough about me talking. I think we all know the difficult patient. We've all had one. They come in with that great hoodie out there, right? God forbid you wear a hoodie because it's cold outside. You go into the emergency room. The hoodie's up there because the wind's blowing against your back. But, if I was a white man walking in there with that hoodie, you're not going to have the same reaction as you do with somebody of color. And so we all know the story. My pain's 9 out of 10. Nobody believes me. They think that, I'm a drug seeker. I really don't know. I don't know how to tell them. Even if they have a treatment plan in front of them, this is what my doctor recommended. It doesn't matter. I'm not going to give you what you want. Here's your medicine. Go home. And guess what? Some of them die from that.
Yeah.
Right? So, the last thing I just want to talk about, and again, I think this is a model that Dr. Smith has put in front of me that I really wasn't aware of until recently, I'm embarrassed to say, was the Kleinman's explanatory model. And it's really about how we need to teach our patients how to ask the right questions to their providers. They might come in and say something in a way that a provider might be saying, oh my gosh, I don't really know where this patient is coming from. But it's almost like motivational interviewing, where you train them to word the question in a way that says, I hear you, to the provider, the provider saying to the patient, I hear you, how can we fix this? Because you're asking me a question that doesn't make me feel defensive as somebody working with you. Me feeling some way that maybe, my perception of how you think I am is different than what you are trying to say. Let's work with our patients on how to ask the good questions. We're going to talk over the next 2 days about how to train all of you how to talk to patients appropriately. But I think it's more important than ever that we also have patients learn how to ask questions in a way that stops putting all of us as providers and team members on our defensive. I don't always believe people have a malice intent when they're coming to you and they're asking you for assistance. But it's like any one of us. If we say things a certain way, and we do things a certain way, then obviously the perception is going to be a way that we didn't want that to be. So, let's speak with them about how to reform their sentences. If you have a tough patient, inpatient, who hasn't thrown a pole at you lately, an IV pole, let's say to them in a certain way, if you have a problem, let's word it a different way. I will help you. Let's write those questions down. Because it's really important that we have a connection between our patient and our doctor, right? They're the lifeline for our patients. They're prescribing the medications for them. They're overseeing their model of care. They're advocating for them. So we want to make sure that relationship doesn't get strained. We've had a couple of those. I had to sit in on a couple of those meetings. I actually kind of like them because usually the outcome is very positive. This is just going more on Kleinman's questions, and I think that we can go ahead and move on. And I really want to just be able to get to Dr. Lawrence. So I think I'm going to just stop there, Dr. Lawrence. I'm going to let you pick up on psychological safety.
You have to click, click it. So, the green, just click green. Okay, so I want to operationalize this a little bit for you, because often we talk about the issue of discrimination, bias, stigma, all of that, but how do we actually do something about this in real life, okay? And so this is called Build It and They Will Come. So I'm asking that question. When we talk about partnerships and we talk about how we work with individuals with sickle cell disease. I try not to call people patients because they're patients at one point in time when they're in your clinic, but they're an individual with sickle cell disease all the rest of the time, right? And so we want to make sure that we use that person-focused language. So individuals with sickle cell disease, we want to team up with them and their families, and as well as patients, as well as physicians, and even community-based organizations. And so when we think about engagement and teams, how do we make multi-stakeholder partnerships work in the real world? And so the first thing that I want to talk about is engagement. And so I do engagement as my main research focus and the main way that I practice public health. And so when we think about the word engagement, what does that mean? So anybody, just shout out your definition of engagement.
Exchange.
An exchange, okay? Active participation, interaction. Together, okay? So if I ask every single one of you in this room what engage means, everybody would have a different definition, right? And so what happens is when I go into a team, that's the very first thing that I get them to do is to define engagement. Because oftentimes what we say in a team or when we're talking about an individual with sickle cell disease is we say they don't engage, right? And they don't engage because our definition of what engagement looks like is different from their definition of what engagement looks like. So we're often holding people to a metric when they didn't even know the standard. So the issue with that is we're constantly going to say that people are not engaging. And so the very first thing that I want you all to do is to define engagement so everybody knows what it looks like when it happens. Okay? So the next thing that I want to talk to you about is the fact that engagement can harm. And so when you think about whatever your definition of engagement is, engagement can be harmful if you don't do it the right way. So first we run in with this great term and we say we're engaging. Everybody thinks it is a different thing. It all looks different to everybody. So there's confusion there. And then we go in and we talk to the same exact people all the time. So that divides communities because we don't talk to people who are less convenient to get to. We talk to the same people over and over and over again. And so that's an issue. So interacting with the same community members each time creates division in communities and you need a new perspective. What about the people who actually are on Medicaid? Don't call me to talk to you about sickle cell disease, right? I have a very different perspective. So how do we make sure that we don't get to just the Dr. Lawrences of the world that's convenient to talk to, and we talk to the people who really are suffering from the individual social determinants of health? Then there's unidirectional communication. So what happens is we are these great researchers and we go and we're these clinicians and we go to these communities and we say, look at the beautiful thing I just built for you. Isn't it nice? Pat me on the back and bet it and say that it is great. And I want you to make sure that you tell me how good I am at this. Right? And that's an issue because the direction, the communication is unidirectional. It's not bidirectional. And so what is happening is that we need to get the information back from individuals with sickle cell disease and their families and then actually do something with it. Okay? So when we think about communication, it has to be bidirectional versus unidirectional for it to work in communities. The last thing is how engagement can harm is if there's lack of follow-up. So often what's happening is when we think about, as researchers, this idea of dissemination, we disseminate things at the end of a project. The end of the project can be 3, 4, 5 years, and if you do disseminate it, you disseminate it in a way that people with sickle cell disease don't even look at. You want to put it in a journal or something like that. They probably won't even see it. So how do we make sure that we disseminate things along the way? So for me, dissemination happens from the beginning of a project. How do you go back and give people information as they have been in a focus group, as they have been given you a survey? How do you talk to them about what you're learning along the way, okay? So when we do that and we disseminate from the beginning, then we have better engagement, okay? So these are things that I want you to avoid so that you don't harm your relationships with communities. And so here are some engagement fundamentals. And I'm telling you these because I want you to make sure that when you are working and you're thinking about how do we get rid of the discrimination, the lack of inclusion in our teams, these are some things that you need to do. So first of all, we need to clarify our roles. So Dr. Smith talked to you a little bit about the Step Up study. So we're going to call it Step Up. So basically what we did in the Step Up study is we compared standard transition education to if I add a peer mentor and somebody else with sickle cell disease, do you do better? Okay? So all the technical terms that you can say about it, that is what it was about. Is a person that has a peer, are they going to do better? So the biggest thing that we did in this study, or one of the biggest things, is we had a model called the triad. And so the triad was our engagement model. So what we did is we took adult and pediatric physicians, that was one piece of the triad. They all had to work with a community-based organization, that is a CBO is what I'll call it from now on. And then they had to have individuals with sickle cell disease as well as their families. They all had to work together throughout the entire study. Now, that sounds great, but getting them to engage and to talk and to really work together was a challenge. And I learned something every single day in this. And so, first of all, there was role clarity. So we had to make sure that everybody understood what they were supposed to be doing in this project. So especially the community-based organization, and then we wanted the individuals with sickle cell disease and their families to feel like they belonged on the team and that their voice mattered. And so what we did was ensure that equitable engagement with the triad. So as you are thinking about this, think about the triad and how we put those individuals together. So as I was thinking about engagement and as we were trying to make these teams work together and figure out what is going on, some of these teams are really what we call engaged and some of them are not. So what is the problem? We learned that it was psychological safety that really brings teams together. And so what is psychological safety? Now I'm going to give you some alternative terminology because you all have just been talking about this idea of diversity, equity, and inclusion and how it's been attacked. And we know that there are some issues with laws and different things that are coming down. But think about this idea of psychological safety when you're trying to build this in your teams. So psychological safety is a shared belief. It's held by the members of a team that the team is safe for interpersonal risk-taking. And so when you think about you going into your teams at work, or if you think about the individuals with sickle cell disease that you're working with, do they feel safe interacting on the team? Okay. So then it's a sense of confidence that the team will not embarrass, reject, and punish someone for speaking up. So has anybody been in a team where you said something and somebody just made you feel dumb because you said something? Yeah, there was no psychological safety on that team, right? Okay, and so a team climate is characterized by interpersonal trust. This is what Shirley was just talking about. You have trust and you have that mutual respect for each other. So that's what psychological safety is. So Google, they did research, and Google is Google, so they were Googling, and they were like, we want to make sure that we have the best teams out there. We are going to research what it takes to have the best team. So they went out and they did Project Aristotle because they wanted to discover what makes a team effective. And so what they found was not that it was who was on the team, but it was how the team worked together. So we often go and we say, I've got this great physician coming in. I've got this great individual with sickle cell disease. They do so great. They do so much. I've got this amazing CBO. I have these amazing people with all this resume and all these things, letters behind their name. But it's not that that's important. It's how the people on the team actually work together. So when we're thinking about how you're building teams and how you're making multi-stakeholder teams work, don't think about the who, it's the how. How are they working together? And so they have to have psychological safety. That is the key. So when we think about psychological safety, they have to feel safe to learn. They have to feel safe to collaborate. They have to feel included. And so when we think about the different quadrants of psychological safety, if those things are not there, up to ultimately being able to challenge the leader and challenge the team. And so if you have ideas and everybody's thinking the same, there's this group think, nobody's able to think different, and then nobody says, oh, I don't think that idea is going to work, or, oh, I have a different idea about this, then you don't have this idea of challenger safety. And that's what we're looking for when we're on a team, okay? So this, if you have psychological safety, what this other piece is, you all have heard of this, the forming, norming, performing, and storming phases of a team. Well, if you have psychological safety, you're able to move through these faster so that you get to that norming stage, okay? So, again, psychological safety in your team is trusting that your team is a safe place for taking risks, asking questions, sharing differences, mutuality of floor time. Do we all get to speak, or is it that when we're in the room with different stakeholders that the physicians always talk and the individuals with sickle cell disease and their families are always quiet, right? Because we have these power differentials. And then how do we take a step away from task to care for stakeholders? And so how do we get out of this is just the job that we're doing to how do we care for the actual people, okay? So here's a scenario. Let's do scenario number 5. You can talk about this for 2 minutes at your team, and we're going to go through this. So scenario number 5, Steve. He is a team leader, upholds high standards, is tolerant of mistakes, and has intolerance of mistakes. Thank y'all. They people need. We got psychological safety right here, but yes, I love it. See, perfect example. We can skip the scenario. All right. They were able to challenge me. See, that's how it works. So when we talk about, let me start over, okay? Scenario number 5. All right. Steve, a team leader, upholds high standards, is intolerant of mistakes, and has strong opinions on how things should be done. At a team meeting, Warren, an experienced team member, suggests an idea that was shot down by Steve. Everyone else thought it was an idea worth exploring. Steve spoke negatively about Warren behind his back afterward, okay? So here's what you're going to do. Discuss ways you could deal with the issue and make the interactions as psychologically safe as possible. So I'm going to go back to this and let you see number 5. All you're going to do is discuss a couple of ways you could deal with the issue and make the interactions more psychologically safe. Okay? All right, 2 minutes. Talk to your team, your table. Okay?
That would never happen.
No. You guys too. Not with Krieger on the team.
I know people like as leader, they don't like to be introduced with new ideas in the team setting. Like
there may be people that you have to lead to the water and make it seem like that's their idea.
Exactly.
As a young physician, that's been often what I've had to learn to do. I don't think it's ideas like that. But that is one of those things. I think it was their idea.
Yeah, like a one-on-one with them and just kind of let them come up with it.
Let them think like they got it.
Yeah.
I feel like just in life in general, a lot of people just have problems with accountability.
Yeah.
And
How are ya? He's so covered.
What's that?
He's here.
Yeah.
Oh, yeah, we love it. Nice seeing you. You look great. I hear you're working out.
yes, ma'am.
Quite a bit.
Yeah,
No
no,
boxing, though. Not
No
everybody's boxing you.
no spar. Yeah, no fighting. Yeah, I'm
You can
not.
box. You just can't let anybody take your head.
Yeah, I realized that. Like, what? That's because I'm getting. I'm getting really getting good.
Getting good, so it doesn't.
And they want
Gonna get one.
no,
See?
no, the coaches want me. I'm not on that. I told Dr. Greer I wouldn't, so I'm not. And as you made a great point. The traumatic brain injury after getting this treatment doesn't really make sense. So, yeah. But yeah.
All right, let's
Thank
get
you.
back together. I know that wasn't much time, but we want to make sure we get to the amazing panel. All right. So, since this table is definitely safe in this room, we're going to let them go first. And so tell us what your thoughts were about scenario number 5. So what is one or two things that we can do to make it more psychologically safe?
So one of the examples that we gave was in that team meeting when Steve kind of backs down Warren's idea that somebody else interjects to say, I think that's a good idea, can we hear more about it? To kind of redirect it. The other piece of that is when it says Steve was speaking negatively about Warren after, who's the recipient of that negative feedback? Because they need to halt it there also to reframe it and circle him back.
Yes. So somebody can speak up and say, hey, that was a good idea, and give a little bit of advocacy and be an ally, right, in that moment. Then we can talk about the meeting after the meeting. So psychological safety is not happening when your team has meetings after the meetings. Okay, so what I mean by that is that nobody's telling the real thing in the actual meeting, and then they're either texting on the side and talking to each other, or they go out by the water cooler and they have the meeting after the meeting, right? So that's an indication that you don't have psychological safety on your team. And I think we all know how that is, right? And so make sure that you allow your people to truly be open and honest in your team meetings, or they're going to have the meeting after the meeting and you're always going to have that divide. Wow, one more group. Oh, go ahead. You want to say something?
Psychological safety is sometimes uncomfortable for people who want to dominate.
Yes. Did y'all all hear that? It's sometimes uncomfortable. Yes, absolutely. One other group about the scenario? Okay. You got it. Okay.
Good morning, everyone. This almost sounds like a conflict resolution situation to me. We were saying that, similar to what they said, Steve Warren should have had an opportunity to explain his idea and been heard and listened to, even if they had to come down to a vote. Yes, no, abstain, and then for them to talk about Warren behind his back was absolutely disrespectful. So, seems like Steve is, what'd you say, hard?
Well, it also sounded to me like Steve could be somewhat of a bully on the low. I mean, because sometimes people who have power are bullies on the low. And they project it in a way that it's like, it's like nice, nasty. And it makes people feel very uncomfortable, and I think he was so used to doing it, in probably in a group meetings that he was like, okay, yeah, I'm gonna, slap one to the side and this is how this is going to be. But in a group setting, you also have to have other people to come and speak up and say, you know, he had a great idea, or like they were saying, you know, let's listen to it. And then at the end, when you're at the water cooler, a lot of times when you're in some situation and, you know, you have your clips and people are gonna talk, and it's like, you have to stop foolishness, you have to stop certain bad behavior, or you have to stop some negativity sometimes, because some people are just very negative, and they don't ever see the rainbow, what could be, what's going on. They just see, well, you know, I may feel that I have more power than this person, or I might feel, and some people feel like they're better than other people. So all of that comes into play when, I mean, that's just how I see it, when sometimes you have a meeting, you know, like you said, some people might have more letters behind their name than others. So it's like a power thing for some people.
Absolutely. And so as we are thinking about this, another tool that you can use to develop this psychological safety is rules of engagement. So we had all of our teams, we had 14 sites that were across 8 different states. These 14 sites developed rules of engagement. And so write that down, that's a tool, rules of engagement. And so here are some things that you could say. Where there's a difference of opinion, stick to the issue, okay? Stick to the issue rather than getting personal. And so oftentimes we start to think about, okay, this is a personal attack on me and all of that. We don't want that. All right, leaders need to have the skills and know how to offer constructive feedback. So again, that goes into not getting personal. If someone is, this is something that she just walked out, but she just said that if someone's discussing a project and taking ownership, ask them who else contributed to give them an opportunity to be inclusive. So oftentimes what happens on teams is that we are like, oh, this person is taking up all of the credit. And so you can be a person that says, this is so amazing, you have done such a great job. Who else helped with that? So that gives them an opportunity to be inclusive and to say, and to give other people credit. And then if you don't have the authority to solve an issue, learn how to de-escalate the conflict and follow up. And this is especially important when we have individuals with sickle cell disease, especially if they're coming to a community-based organization and they're complaining about the clinic, or they're saying something that is negative. How do you de-escalate that? How do you communicate with the physicians and let them know, or in keeping in confidentiality, help them to resolve the issue, okay? So developing rules of engagement. We got these rules of engagement, and this is something that you all can use in your teams. We got it from firefighters. So what firefighters do is they have these rules of engagement. And I love number 6 the most. Go in together, stay together, and come out together. And so with your team, what you can do is talk about what are your rules of engagement going to be, especially when we had physicians and community-based organizations and individuals with sickle cell disease. We wanted to know what are the standards that we're going to follow as we engage these groups of individuals. So what we did is gave all of the teams the rules of engagement, or firefighters, and then had them to develop their own 11. And so you do this, and it's a lot of fun to see what they come up with. And then, so that was the instructions for that. We also, one thing that you can do is the help analysis. So what we did is when we went into the team, we said, what is it that was the history of engagement? So if you're building a team and you need to engage, we found out there was a lot of stigma, there was a lot of bias, there were a lot of things that happened between at the hospitals. How the hospital was even established was an issue, right? And so it was like sometimes only white people could go to this hospital, and then black people, and then all of that was just trickling down, right? And so this is something easy for you to do, and it's called the help analysis. Okay, so help. What is the history and the context of our engagement? So you're sitting around with your team, and you're going to talk about this to get it all out on the table. Then E is engagement. How has that history affected how you've worked together in the past? So that's important. You need to know how that history is affecting you. What do we lack? So So what do we lack in our group, in our resources, in our anything that we need to be able to move forward? And then P is how do we progress? So what you'll get is engagement strategies that are tailored and that are not just cookie cutter that you have pulled out of some literature or something like that. This really helps you to engage with the group and organization that you are working with. And so this is just a slide about the rules of engagement and a communication plan. So what we did was we have the rules of engagement, but then how are you going to communicate across the different stakeholders that you have? So how are the physicians going to communicate with the individuals with sickle cell disease? How are they going to communicate with community-based organizations? And what we saw happening is that the physicians will want to develop a program for people with sickle cell disease, and then the community-based organizations will want to do the same thing.